My topic for today's presentation is video presentation to demonstrate right-sided approach to right-sided lumbar synovial cyst by a right-handed surgeon using right-sided portals by UBE. The case is done by Dr. Ashwin Kumar Khange. These are his disclosures. The problem. Right-sided pathologies may be difficult to tackle standing on the left side of the patient. Standing on the right side is challenging to endoscopic spine surgeons as it is not natural for a right-handed surgeon. The solution. First, stand on the left side, make the portals on the right side, mirror image of the left side. The problem here comes is the spinous process pushes the scope and instruments towards the facet joints. Second, stand on the left side, portals on the left, but work on the contralateral side. This is the contralateral sublaminar approach reserved for experts. Third, stand on the right side, make the portals on the right side, mirror image of the left side. Use the right hand cranially to hold the scope and train the left hand to do the surgical maneuvers. In our technique, we stand on the right side, we make portals on the right side, and the right hand is the working portal, is towards the cranial side. Viewing portal or the camera portal is 2.5 centimeters to 3 centimeter caudal to the working portal on the medial pedicular line. So this is a routine AP and lateral X-ray of the lumbosacral spine. You can see this is the medial spinous process line. This is the medial pedicular line. The surgeon here is standing on the left side. This is the spinolaminar line. This is the trajectory for the viewing portal. This is the trajectory for the working portal. Here the viewing portal is on the cranial side. This is the viewing portal and this is the working portal. Similarly, on the right side, this is the medial spinous process line. This is the medial pedicular line. This is the spinolaminar line. This is the trajectory for working portal and this is the trajectory for the viewing portal. Here the surgeon is standing on the right side and the working portal is on the cranial side. We are elevating the multifidus muscle, creating a working space with a number 7 knife handle. Here you can see triangulation is being done. The surgeon is standing on the right side. This is the typical OT arrangement of unilateral biportal endoscopy. It is of utmost importance that the staff and the nurses are well oriented to the irrigation system. This is a different case, but just for where the surgeon is standing in the technique. Here I present to you a 64-year-old retired oil and gas employee presented with right posterolateral leg pain since 5 months. Pain partially relieved with physical therapy and NSAIDs, but recurring after stopping medicines. The VAS score for back was 3 on 10 and the VAS score for leg was 8 on 10. No pain on the left leg. Neurogenic claudication was after 10 minutes. This is the flexion extension dynamic X-ray, standing X-rays of the patient. This is the MRI. We can see here that at L4, L5 level, there is a down migrating synovial cyst along with degenerated age-related disc. In the axial image, we can see a paracentral synovial cyst on the right side. So the clinical dilemma of the surgeons comes after so many options that to treat it conservatively or to operate. So the surgeon can choose to either endoscopic decompression transforaminal, to do endoscopic decompression interlaminar, or endoscopic decompression unilateral biportal endoscopy. We performed unilateral laminectomy for bilateral decompression by unilateral biportal endoscopy at L4, L5 level from the right side of the patient. Here you can see a superficial phleum is being removed using a curette. And here you can see in the below video that deep hemiphlebectomy is being done and you can see the underlying tissue. This is a short video demonstration of the procedure that we did. We have marked which is the cranial and the caudal side. Probing is being done here to safely get through the disc. Continuous irrigation system is necessary for a better visualization. We are using to remove the synovial cyst and the disc ballpoint nerve hook. Pituitary forceps are used to remove the synovial cyst. Only swiping movements are done, not cutting movements, because sometimes the synovial cyst might be adhered to the cauda. De-roofing of the lateral recess and is done and is checked if any remnant is left. So the literature on this was very minimal. In operative neurosurgery, the paper by Jin Sung, it highlighted that biportal endoscopic decompression of facetal cyst can be performed with good clinical and radiological outcomes. This is another case of 10 patients. UBE is an optimal option for synovial cyst excision of facet cyst excision with lumbar canal stenosis. 30-degree optics by arthroscope provides HD, magnified, illuminated, and bright image of the posterior spinal anatomy, helping surgeons perform precise surgical maneuvers with minimum risk to the underlying neural structures. Thank you.